sitting on a big blue bus. So the S sounds and the V sounds are produced they require lip competence and the tongue to be able to touch the front teeth. And so all that we would quite reasonably expect to improve when we change a large class 3 to a more appropriate class 1 incisor relationship. There is an involvement of some of the plosives and velopharyngeal competence in that, but that first part we would expect to improve like any orthognathic surgery with appropriate positioning of the lips. The second important part is the big blue bus, and that's really a demonstration of velopharyngeal closure and competence. So velopharyngeal incompetence, which I'm sure everyone's aware, but for the students who are here, is a speech disorder that results from failure of the velopharyngeal mechanism to seal adequately, which then allows air to escape inappropriately through the nose. And figures are difficult to obtain, but somewhere between 11 to 24% of cleft patients will experience a decline in their velopharyngeal function following orthognathic surgery. If you look carefully and listen carefully, I think it's probably more than that. But the muscles will adapt, and with learning new speech patterns, these patients can often have improved speech because they gain better intelligibility with their fricatives, their S's and B's. So velopharyngeal incompetence will also be related to prior changes to the port or the three-dimensional diameter, and it's important to remember Poiseuille's law that the flow through a tube is related to the square of the radius. So we really don't need to change the dimension of that tube very much to push a patient who's just managed to achieve velopharyngeal competence to someone who no longer can achieve. Now, I was going to show you a demonstration of speech here, but it's seen to have quite complex velopharyngeal incompetence, but very understandable beforehand. And unfortunately, the video is not running. So if we just look purely at the posterior maxillary advancement, we can see that the posterior maxilla in a horizontal dimension is moving between 5 to 9 millimetres. Now, you might expect that would translate to the soft palate coming forward 5 to 9 millimetres, but it doesn't. Why? We don't fully understand, but it's largely due to the manipulation of the soft tissue attachments and the complexity of that area, because if we look at this, all we consider is the horizontal movement. There will also be a vertical movement if we use maxillary rotation, which can aid in that closure of the velopharyngeal complex. So I think the message here that it is difficult to assess and that simply using a two-dimensional is not going to be the full answer to the question. So, as I was saying, there's significant variation in the studies, and there are multiple factors. The degree of advancement, there are papers who divided up into up to 4.27, they decided would probably not have much change. Once you started looking at 7.5 millimetres, then you could expect some change. And from 10 millimetres, you need to be careful because that might produce some irreversibly detrimental changes. And you know, if we think of it from the patient's point of view, when they go home after surgery and they go back to university or work, none of their colleagues and friends are going to say, oh gee, I think your maxilla's a little bit deficient. But they are going to say, oh, what happened to your speech? So a slightly deficient maxilla but good speech is an ideal outcome in prep. So the tip here is that we need to be cautious with any advancement greater than 5 millimetres. And we also need to undertake any additional management of the soft tissues and muscle attachments that we can at the time. And yes, that will take extra time during the procedure, and yes, we need to allow that extra time to do it all carefully. So, if we look at symmetry, often in cleft patients, everything is asymmetric. And you know, that sort of saves us a little bit. The other thing I would say is that asymmetries are normal. So, I often like to balance the asymmetries between, I would like to look at the forehead and the neck and the chin, rather than concentrating on the teeth and the lips. So I try to consider a line that starts at the top of the patient, runs down to their neck and chest, and use that as the midline. And chin asymmetry is quite important. People will notice that. Friends and relatives will notice the chin, but in a cleft patient, and I said this often saves us, a little bit of upper midline asymmetry won't be that obvious. The orthodontist will be very grateful if the canines are in a good relationship. And that's very important for function and stability. So let's not get hung up about this area here and look at the bigger picture for the facial symmetry and accept that we're going to have some asymmetries. So once we get to surgical planning for asymmetry correction, we need to think about the planes and the lines that we can see clinically. So no one can clinically see the SM line, but we can see nasium perpendicular, we can see franca horizontal, and we can see a maxillary cant. So these are the critical lines to use in surgical planning. And then once we start to look at the mandible and the genioplasty, here's where a little bit of creativity can help and three-dimensional thinking. So often the asymmetry will be reflected in the chin, and we can devise an asymmetric genioplasty that might be short on the left and long on the right, and this can give us a little bit more body prominence, as well as just thinking about the chin. The other thing with the chin is, although it might be nice to advance it in something in relation to the forehead, really we have to remember that it has to still sit within the soft tissue and muscle envelope, and that chin is going to sit quite neatly. But if we did a big advancement here, we risk getting some lip incontinence. So again, compromises. So the nose, as I was saying, during the orthognathic surgery, we have the best access to the nose. And this is a good example of how the nose sits on the skeleton. If you get depression here, of course this is going to be depressed. And this is not going to be fixed by a rhinoplasty. It's going to be largely, the start of the fixing of this is going to come from the bone graft down here. Look at this septum. We've made that dramatically worse by correcting the cant. So, I keep saying surgery to reposition the muscle attachments and soft tissue is important, and the periosteum is important in all the surgical specialties. The periodontists know that the periosteum is important, and we should respect the periosteum because it forms the origin of of the muscles. Accurate and careful repositioning of the periosteum translates to repositioning of facial muscles. And the periosteum, of course, will encourage bone healing over the osteotomy gaps. So the periosteum really is the surgeon's friend. It's not that stuff that we have to get out of the way before we get to the real business of the bones. It's the thing that we need to preserve. Post-operative management, we need to be very aware of the palatal width and make sure we retain this. As you can see the large defect there. Relapse, there are a number of contributing factors, including the amount of advancement, the downgrafting, osteotomy gaps, and elastic guidance will be important during the healing phase. But probably there's no single factor that is going to affect relapse. And if you don't address all of them, you're probably not maximising the ability to get a stable result for the patient. So, in conclusion, cleft orthognathic surgery will involve compromises. And that is the art of cleft surgery. The final successful outcome is achieved over at least 20 years of growth, planning and preparation. And sadly, that unfortunately is probably about one surgeon's practicing career. So if you don't look at your outcomes and other people's outcomes early on, it's a bit late at 20 years to be suddenly discovering there's something you should have done better 5 years, 10 years ago. So outcomes are important. And we need to learn from those outcomes. So again, I thank you for the multidisciplinary international collaboration that we've had over many years. And I think we take information back to Australia after these conferences and these visits to the hospital, just as our discussions share information. So thank you again.
Thank you, Dr. William Besley, for your very interesting and challenge